Our next speaker today is Associate Professor Genevieve Steiner. Genevieve is an Emerging Leadership Fellow and Director of Research at the Health Research Institute of Western Sydney University. Her cognitive neuroscience research spans the early detection, prevention and treatment of cognitive decline in older people with the aim of reducing dementia risk and improving quality of life. Please welcome Genevieve. Her presentation is titled CBD for Mild Cognitive Impairment and Alzheimer's Disease. Thank you.
Hi, my name is Genevieve Steiner and I'm going to be talking to you today about a hot topic in dementia research, cannabis, which is a budding therapy that all of us are very interested in right now. I'm based at the Nickham Health Research Institute at Western Sydney University. And before I start, I would like to make a declaration of interest that I have received funding for cannabis research from medicinal cannabis companies based in Australia. I'll be talking to you today. I'll provide a definition of dementia and Alzheimer's disease to give you a little bit of context on why this is an important area to investigate with cannabis. The endocannabinoid system is disrupted in AD, so I'll be giving some background on that. Then I'll review the evidence on the efficacy and safety of available cannabis treatments for dementia, CBD, THC, as well as combination therapies before finally going into some clinical considerations for the treatment of dementia with cannabis. Now, globally, dementia affects over 55 million people in 2020. Now, this is expected to escalate all the way to almost 139 million people by 2050 and cost around 2.8 trillion US dollars per year by that point. If we think about dementia as a country, it's the world's 18th largest economy. And the cost of dementia is set to outstrip the defence budget by 2050 in the US. Now, in Australia, it affects many people that are over the age of 65 years. In fact, it's our second leading cause of death overall and the leading cause of death in women. It's also our leading cause of disability. Now, Professor Ron Peterson, who is thought affectionately to be the grandfather of mild cognitive impairment, which is the early stage of dementia in the US, very famously said that this disease is going to bring down the healthcare system in the US if we don't act now. So it's a very important and pressing issue with our aging population. Now, dementia itself is actually a clinical syndrome. It's not just one specific disease, it's a series of symptoms that are caused by over 100 different types of diseases. Alzheimer's disease is the most common cause of dementia, affecting somewhere up to around 70% of all dementia cases, followed by vascular dementia, as well as other types beyond that, including Lewy body, frontotemporal dementia, etc. The clinical presentation of Alzheimer's disease is characterised by a decline in episodic memory. That's our autobiographical memory, so our ability to remember conversations and recent events. It's also characterised by impairments in functional ability, and in the later stages what we see are behavioural and psychological disturbances. And so these are what we think of as neuropsychiatric symptoms, disturbances in perception, thought content, mood and behaviour. So things like depression, anxiety, aggression, agitation, hallucinations, even sexual and social disinhibition and sleep-wake cycle disturbances. The pathophysiology of Alzheimer's disease is complex. It involves the deposition of amyloid beta plaques and the buildup of neurofibrillary tangles from hyperphosphorylated tau protein, neuroinflammation, oxidative stress, synaptic dysfunction. All of this leads to a cycle of cell death and neurodegeneration. The treatments for Alzheimer's disease are limited. In the last 20 years, we've mostly seen changes in symptoms with acetylcholinesterase inhibitors and NMDA receptor antagonists. And recently there was an approved monoclonal antibody agent, aducanumab, by Biogen with the US FDA, and this addresses amyloid beta clearance. However, it doesn't seem to have much of an effect on cognitive symptoms. There's no cure and no way to delay or halt Alzheimer's disease's degenerative course. Unfortunately, for a lot of people with Alzheimer's disease, this leaves us with very limited options, and we desperately need a new approach. We need to be looking at new leads that address new targets that could be relevant for Alzheimer's disease, and medicinal cannabis is one of these promising areas. Now, this is specifically because we know the endocannabinoid system is disrupted in Alzheimer's disease. So we've seen a range of different aspects that are disrupted. And so, as most of you know, the endocannabinoid system comprises receptors, CB1, CB2, the endocannabinoids, and the enzymes required for their metabolism as well. Now, the CB1 receptor, we've seen its expression altered in the early stages of Alzheimer's disease, where it's actually increased, and then the expression decreases in later stages. This is particularly in areas that are relevant to Alzheimer's disease pathology, including the hippocampus and the frontal cortex. So it's likely some kind of a compensation mechanism. We see similar changes with CB2 receptors as well, where they increase in expression in key brain regions related to Alzheimer's disease, the entorhinal cortex, the hippocampus, the parahippocampus. We think this is probably due to the increased microglial involvement due to CB2's abundance in its expression in immune cells. Now, this overexpression correlates with increases in Alzheimer's disease pathophysiology, including amyloid beta 42 concentrations and levels of hyperphosphorylated tau and neurofibrillary tangles. We also see changes in AEA concentrations, so the endocannabinoid. We see in the frontal cortex that these decrease, but when we look at the serum, there don't seem to be any changes. In 2AG, there's increases in concentrations and its activity is altered as well. It could perhaps be some kind of a protective mechanism that we're seeing here. In terms of the enzymes, MAGL expression increases as Alzheimer's disease progression advances. And this has specifically been observed in hippocampal neurons. FAAH expression and its activity increases as well. And this has been in the dentate gyrus, the entorhinal and parahippocampal cortex, and high levels have been detected close to amyloid beta plaques and hypertrophic astrocytes as well. But what's interesting is that there seems to be limited evidence at the moment on the link between these endocannabinoid system alterations and the cognitive deficits that we see in Alzheimer's disease. Now, in terms of tackling some of these endocannabinoid system disruptions with cannabis-based therapeutics for Alzheimer's disease, well, traditionally, we've actually been using cannabis since more than 4,000 years BC. It's been dated back to Central Asia since the Neolithic period to treat senility, boost cognition, and longevity. Now, cannabis sativa itself contains more than 100 phytocannabinoids and other compounds, such as terpenes, etc., that might be relevant to AD pathophysiology and its clinical management. And it has the potential to address multiple aspects of AD pathophysiology, unlike the current therapeutic approach, which just looks at some symptomatic relief or targeting A-beta specifically. So this can affect potentially a range of symptoms in dementia as well. So Ethan Russo and his colleagues have gone through and summarised some of the symptoms of Alzheimer's disease and how different elements and constituents of the cannabis sativa plant might address those symptoms. So anxiety in dementia might be addressed with CBD, low-dose THC or linalool. Psychosis could be addressed with CBD, insomnia or restlessness, some of these later BPSD-related symptoms with THC and linalool. Anorexia with THC due to its ability to increase appetite, aggression with THC, CBD or linalool, depression with THC, limonene or CBD, pain with THC and CBD, as we already know, memory-related changes with alpha-pinene and THC, and the neuroprotective effects of CBD and THC could also be an advantage to treating Alzheimer's disease pathophysiology, as well as changing the amyloid plaque formation with THC, CBD or THCA. Now you'll see that there's some common suspects that are emerging throughout this list. So CBD is obviously a big one here, addressing multiple aspects of pathophysiology and symptoms. And the other big one is THC. And so I'm going to go through and now talk about some of the evidence, both preclinical and clinical, on the use of CBD, THC, and then their combination for the treatment of Alzheimer's disease. Now, there's quite a body of evidence that's been building up for using CBD for Alzheimer's disease from the preclinical point of view. Its mechanisms of action have been quite well defined in vitro and in vivo. Now, this includes preventing cortical and hippocampal neurodegeneration, reducing amyloid beta production and tau hyperphosphorylation, protecting against neurotoxicity, both from amyloid beta and from microglial activated neurotoxicity. Anti-inflammation and antioxidant properties have been demonstrated, specifically around the regulation of microglia. CBD has also been shown to prevent the transcription of pro-inflammatory genes and increase cell survival by reducing apoptosis, to promote neurogenesis. And then in animal studies, there's been quite a body of evidence here that's been built up by my colleague, Professor Tim Carl, and his team. Now, what they've been looking at are different models for Alzheimer's disease, the APPPS1 transgenic mouse model, which is an amyloid model, and also in the tau 58-2 model, which is a tau model for motor neuron disease. So in the amyloid model, they've shown that CBD can prevent and reverse social recognition deficits and improve novel object recognition and spatial learning. And in the tau model, it's been shown to improve spatial recognition, spatial reference memory, I should say, reduce anxiety and decrease contextual and fear-associated learning as well. So there's been a range of different behaviours that have been able to be altered with CBD. I think one of the most exciting ones here is around the prevention of cognitive deficits, because obviously that has some potential relevance to people with mild cognitive impairment or the early stages of dementia. So we may be able to prevent people from going on to develop dementia at a later date if treatment with CBD is shown to transfer from animal into human models. Now, in terms of the clinical evidence, this is what's interesting, because from other studies and other populations, people without dementia, we know that CBD is well tolerated and that it has low toxicity and it's non-intoxicating. We know that high doses are tolerated quite well. Some studies have shown up to 1,500 milligrams a day can be tolerated orally. It's also eliminated slowly. But in terms of any clinical evidence for just CBD as an isolate or as a plant extract, there's actually no published randomized controlled trials on CBD for dementia yet. There are several trials underway at the moment. So in April, I conducted an extensive search of the US clinical trials registry, same with Europe, and also the Australian and New Zealand clinical trials registry. And across the various components that I'm going to be talking to you about today. And CBD, there's 3 trials that are currently ongoing. So in the US, there's a 6-week trial that's looking at 90 milligrams of CBD per day for Alzheimer's disease or mixed dementia that also includes Alzheimer's disease. They're looking at some of these BPSD-related symptoms for dementia, agitation and aggression, and they're also interested in the outcomes on caregivers as well. In the UK, there's a 6-week trial looking at up to 600 milligrams a day of CBD for Alzheimer's disease. Now, this trial commenced in April 2020. It's still ongoing. And again, looking at BPSD-related symptoms. And in Australia, we know there's a trial that's in planning from our colleagues that are at the University of Wollongong. That's at the Acre Centre there, led by Dr. Jess Mills, looking at the early stages of dementia, a 12-week trial of up to 300 milligrams of CBD per day. And they're interested in looking at some mechanistic outcomes, such as changes on brain structure, so hippocampal volume, like what they've demonstrated in their chronic cannabis users. And they've registered this trial last year, but it's not actually recruiting yet. So we're very eager to see what happens there. Now, in terms of THC, this has actually been an area that's been, I guess, quite well explored in terms of clinical evidence. So let's start off looking at some of the preclinical evidence. So we know quite a bit about the mechanisms of action, both in vitro and in vivo for THC. We know that it protects against excitotoxicity, oxidative stress, and it reduces microglial activation. We know that it promotes hippocampal neurogenesis, and it's also been shown to inhibit acetylcholinesterases. It's been shown to prevent amyloid beta aggregation and reduce tau. Now, in animal studies, it's also been shown to reduce pain, improve mood, improve cognition and behaviour in aged mice. And in a inflammation-induced cognitive decline model, it's also been shown to protect against brain injury. Now, in relation to the clinical evidence, this is a quick summary of the only published randomized controlled trials that I'm aware of for Alzheimer's disease dementia or mixed dementia using THC. So there's 6 published studies from 6 published RCTs from 5 unique studies. So one study was published twice as a primary outcome and then as their sub-study. So what they've all looked at, these 6 trials, is whether or not THC can improve behavioural and psychological disturbances in later stage dementia and whether it has an effect on gait and balance. So these 6 trials range anywhere from 3 days up to 14 weeks. So it's quite variable how long people have been dosed for. They've been looking at dronabinol, which we know as a synthetic THC. They've looked at THC, they've looked at nabilone, and the doses have been from 1 to 5 milligrams per day. Now, across these studies, there's been an interesting range of findings. What they've shown is a reduction in anorexia, which has been indexed by increased weight gain, because appetite is often one of the things to change in people that have later stage dementia. A reduction in nocturnal activity, so some of this sleep-wake cycle disturbance, and then also a reduction in agitation. What's important is that there haven't been any major effects on mobility or falls that have been demonstrated, and the adverse event profile has been quite mild. So sedative effects, tiredness, somnolence, these are the kind of things that we'd expect. Euphoria as well, obviously, people were feeling perhaps a little bit high. Now, importantly, even though these are randomized controlled trials, they're very small studies. There's a high risk of methodological bias in them as well. So although this is promising and the outcomes are looking potentially positive, we've got to take these findings with a grain of salt. Importantly, there are a number of other trials that are underway. So I mentioned there were 6 published RCTs, but there's also another 9 published studies that have been done, but they're all non-randomized and uncontrolled trials. So I haven't summarized the evidence today, but there are another couple that are ongoing at the moment. So in Canada, there's an Alzheimer's disease trial that's looking at 8 weeks of up to 2 milligrams of nabilone per day for agitation, and that commenced in February last year. And in the US, another Alzheimer's disease trial of just 3 weeks, but a higher dose, so up to 10 milligrams per day of THC, which is quite a substantial dose, looking at agitation. Now, that one commenced in March 2017, but it's quite a large trial, recruiting several hundred participants. So it's still ongoing at the moment as far as the registry record is concerned. So I'm going to move to combination therapies now, and that is the, when I say combination, I'm talking about CBD and THC together. Now, in terms of the preclinical evidence, look, there's quite a lot that's been conducted here as well. We think that combining CBD and THC together might have better therapeutic potential than just looking at one of these particular cannabinoids alone. Now, this is because when we combine them, the entourage effect occurs, and we think that there's probably a less severe adverse event profile in dementia, as it's been demonstrated in other populations, such as in epilepsy. CBD might reduce the psychoactive effects of THC, and lower doses of CBD are then also required because there's an increase in the therapeutic index of CBD by adding a little bit of THC into the mix. It's also more cost effective because we can start looking at things like whole plant extracts rather than taking just isolates or synthetic compounds, and obviously the entourage effect as I've outlined. Now, in terms of the animal studies, there's been neuroprotective effects demonstrated from these combination therapies, reduced oxidative stress, reduced amyloid beta 42, increased in learning and memory. And in terms of the clinical evidence, at the moment, there's no published work. However, there are a number of ongoing trials. This is a really exciting area, I think. And so if you have a look here, we've got 5 ongoing trials at the moment. There's a couple in Israel, there's one in the UK, and there's one in the US. 4 of them are looking at Alzheimer's disease and just 1 looking at dementia that's not defined. And the range of the CBD to THC formulation, it varies quite a bit. What's important to note is that all of these trials are looking at BPSD again, so these later stage symptoms in Alzheimer's disease, anxiety, changes in behaviour, aggression, these kind of, agitation, these kind of behavioural disturbances. And they're all very recent, commencing within the last 1 to 2 years. And there's another one that completed in August 2019 in Israel that hasn't been published yet. So I'm keen to see those outcomes too because it was a slightly longer trial with a slightly more CBD dominant strain. Now, this brings us to the research that we're conducting here at Western Sydney University, looking at cannabis for mild cognitive impairment, that early prodromal symptomatic phase of Alzheimer's disease. So across my lab and Professor Tim Carl's lab, we have developed an Alzheimer's disease medicinal cannabis research pipeline. We've partnered with ANTG to run human and mouse studies to try and get cannabis formulated for Alzheimer's disease out of this valley of death from the drug discovery pipeline. So we're focused here in this preclinical efficacy through to clinical trials, phase 1 and 2 at the moment. What we're looking at is a double-blind, placebo-controlled phase 2A randomized controlled trial. We'll be dosing individuals with MCI for 12 weeks with up to 200 milligrams per day of a CBD-rich whole plant extract. It's the Eve strain from ANTG. We're focusing in on people who have amnestic mild cognitive impairment. So that's MCI specifically with memory deficits, because we know that these individuals have an increased risk of developing Alzheimer's disease at a later date. And we're exploring the efficacy on cognitive function. We're also looking at safety, feasibility outcomes, and some mechanistic outcomes in terms of addressing disease pathology as well. We're interested in lifestyle, function, psychological health, and we'll be looking at inflammation, A-beta 42/40 ratios in the plasma, neuronal network function, as well as how the cannabis treatment affects metabolic profiles in these individuals. So there'll be more on this trial shortly. We're about to register it on the ANZ CTR, so keep a lookout. I'll hopefully be able to update you with some maybe preliminary outcomes or at least some progress at the next conference. Now, just moving on to the final part of my talk, which is just around the clinical considerations. So if you're a clinician, you're thinking, I have a person who I'm treating who has dementia or Alzheimer's disease, and I'm interested in prescribing medicinal cannabis. Well, there's some important considerations you need to think about when prescribing. Individual differences in the endocannabinoid system tone are going to affect people's response to the treatment. You have to also take into consideration important factors such as a person's age, their gender, ethnicity, and genetics. The formulation and dose needs to also have careful consideration based on the disease trajectory and symptoms as well. So I've largely talked to you today about using, for example, THC to treat the behavioural and psychological disturbances in later stage Alzheimer's disease. But what about looking at people who are in the earlier stages and trying to improve cognition so we could potentially prevent dementia from occurring? So it depends on what your target stage is in dementia as to how you would need to formulate and then dose people. So are you looking at prevention or prophylaxis in early stages, in which case you might want to think about a more CBD-rich strain or perhaps CBD isolates? Or are you looking at remedial behavioural management in later stages, in which case you might look at something that's more THC dominant? So you've also got to think about the administration preference as well for people, various changes in bioavailability and for potential disease-related restrictions. So for example, if you're looking at somebody who has late stage Alzheimer's disease and you're trying to manage pain or severe, behavioural or psychotic symptoms, and this person has difficulty swallowing, then a capsule is not going to be ideal for that person. You might want to think about looking at an oil or something like that instead. We also have to think about the impact on activities of daily living. So if you have somebody who has younger onset Alzheimer's disease or is quite functional, they might have caring responsibilities, or they could still be working or managing their own finances, etc. Now, these sort of individuals are not probably going to want to give up driving if that's a key part of their lifestyle. And so prescribing a THC-rich strain is going to obviously place restrictions around their driving. And so you would need to think about that and discuss that and have careful consideration with your patients. Polypharmacy is also particularly important to note, especially in older adults where multimorbidity may be a consideration and people are already taking multiple medications. And then you've got the potential for adverse effects with cardiovascular and respiratory diseases that we know of, as well as individual and family history of psychosis, particularly around THC, and individual history of cannabis or drug and alcohol dependence and abuse. So as a quick summary for today's talk, I've given you an overview of CBD, THC and combination CBD, THC for Alzheimer's disease and dementia symptoms and pathophysiology. Now, there is emerging evidence from in vitro and in vivo studies. However, at the moment, there is really not enough evidence from human studies. And this is where we all need to get together and produce that body of evidence to support the use of cannabis for humans with Alzheimer's disease and dementia. The most evidence to date from human trials is really around using THC to reduce BPSD in late stage dementia. However, there's a small number of trials that have actually been conducted and they have a high risk of bias. In terms of the clinical considerations, you might think about, you've got to consider individual differences, formulation, the dose, the administration route, what kind of adverse events you might expect, whether polypharmacy is an issue due to multimorbidity, whether your patients have a history of psychosis or drug and alcohol abuse. So thank you very much for your attention today, and I do hope that you've enjoyed the talk. Here are some of the references that I've cited throughout, and I do hope that you enjoy the rest of the conference. Thank you.
Thank you so much, Genevieve. Thank you. It's terrific.